from where we are at the moment, I can't see that's going to happen because the NHS doesn't seem at the moment to have what I would call the leadership and management capacity to make it happen within the resource that's available.
Welcome to Health Chat, the UK's #1 health and social care podcast. We discuss the most important issues in the healthcare sector and the challenges our colleagues face from the front line of delivery to decision-making in the boardroom. Join me, your host, Dr Ghaffar, as we speak with interesting people from across health and social care and bring you expert insight and discussion on the topics that matter most to healthcare professionals. Welcome everybody, I'm Dr Atif, Medical Director at Health Group, and welcome to the Health Chat podcast. This is episode 2, and I am privileged to welcome Dr Fay Wilson, my colleague here. And Fay is an accomplished GP. She is also director at Badger Group in Birmingham. Now, that's just tip of the iceberg in terms of Fay's accomplishments and what she's actually done in the past. So I'm going to ask Fay to kind of introduce herself and explain some of the things that she's been doing over the years. Fay, over to you.
Well, I've been a GP since Margaret Thatcher was Prime Minister. She got in before me, but I lasted longer than her. So I've actually lived through, and I can't count the number of NHS reorganisations that I've been through, but in particular general practice, of course. And all through my career, I've worked as a GP and I've done other things as well. So I've been a GP, I've run a single-handed practice, I've been in a bigger practice, teaching, training and all the rest of it. I've been on the Health Authority as a commissioner, I've been in the BMA for a long time, and I've been on the BMA National Council and the National GP Committee and all this. And I've also worked locally, trying to bring GPs together and so on. And of course, I've seen a number of changes in the way the system works, with regulation coming in and the CQC coming in. And amongst the things that I've done is looking for different ways to do things. And this has all been sort of sat alongside my work as GP, which is, the first reason I became a doctor. I wanted to be a GP.
Now, this is incredible. And for the younger members of the audiences watching this who've probably newly qualified, say in the last 5 years or so, they probably won't even understand the concept of healthcare records being kept on paper and stored in filing cabinets and things. And if you just go back to when you became a GP, what were your thoughts and aspirations of what you were trying to do, and how have those changes impacted on what you're trying to do?
Well, it's interesting that you say that, because I suppose I went into general practice the same reason that doctors now go into general practice. I wanted to be a personal doctor for individuals. I want to make a difference to their lives, keep them healthy, get them better. And that one-to-one doctoring. And of course, when I did my training and so on, you were looking at all records were on paper. Now, I know some records are still on paper, particularly in the hospital sector. This is an area where GPs got ahead. So the things that still make my heart beat are the individual patient, their personal journey. Now, of course, as you move on, you realise that in order to help an individual, you actually have to look at populations. So I will never be a public health doctor, but I get it, because if you're a public health doctor, you're looking at how can we prevent this whole population from dying younger? How can we keep them weller for longer? And so on. And so I get that. But my heart says to me, this individual who's in front of you is your only patient, and doing that. So being able to run both of those things together, ride both of those horses, if you like, has been one of the things.
Now, you were one of the early champions and pioneers of actually getting practices working collaboratively and sort of sharing the workload as such. So just tell us about the inception of Badger. What does Badger stand for, and how did it come together?
Well, there was a predecessor to Badger as well. I was picking up on what you said about computers. I want to take you back even further. Sorry about this, back to prehistory. And you talked about records being written. And one of the things that I remember doing in my little practice before Mrs. Thatcher had left, was get one of the very first GP computers in, which was called Genesis Junior. There won't be anybody watching who remembers that. It was a predecessor of GP computers. And I remember explaining it to people who I was working with as, think of it as a filing cabinet with the notes in, but it's easier to get things out, it's easier to find them and all this sort of thing. And so everything I've done since then that was the start of it. I think of myself as a sort of slightly, I'm not really an innovator, but you might say I may not even be an early adopter, but I'm enthusiastic about change. What's the potential here? So the next thing that happened, the first big reorganisation was in 1990, and I think after that GP fund holding was brought in, which was about getting GPs into commissioning. And I can remember the saying then that several people said that a GP with a checkbook can make more difference than hundreds of planners trying to change the system. And it was true, because the GPs were able to say, we're not paying the bills unless we get the discharge summaries, unless we get the records, unless the patient actually got the service. And we know, because the patient comes and tells us, they cancelled my appointment when I arrived, whatever. And in order to do that, in central Birmingham, the practices were mostly too small. But it got to a point where, and actually we were ideologically against it, of course, because I'm a very ideological person. But it became obvious that if we didn't do it, the resources were all going to go to all the practices who were better off and who could, who were big enough already and who could do it. So their patients who were already getting a good service were going to get a better service, and our patients, the mass of patients in Birmingham, were going to just fall behind because the health authority couldn't do what we could see the fund holders were doing. And so we said, instead of having a sort of first and second class, everybody into first class, right? Everybody who wanted to join. And at one time we had a third of the GP practices in Birmingham were in the multi-fund. So we did it as a fund holding cooperative. So no individual practices going off with their bag of swag, to increase the profits. It was managed, but it was a cooperative. And that was my first experience really of getting GPs together in a big group. So ambition, nobody had done anything like this size before. The ambition of doing it and saying, if we all put our little bit in together, we can make more. It's more than just addition, And Badger came out of that. So everybody was getting fed up with doing their out of hours. And we thought we need to convert this all-night commitment that practices had, or they did on rotas, or they contracted out with a private company to do their out-of-hours visits, because everything was done by home visiting. The workload was going up. Meanwhile, the daytime workload was going up. People couldn't get up. People couldn't keep going like that without sleep at night, and yet working all day as well, and covering all the weekends. And so a new system was brought in, and we thought, if we all got together, we could do something bigger and better. We could make change, and we could change the system. And it's extraordinary to think now how quickly Badger happened. Badger, the two last letters are ER, emergency room. And we wanted to change the culture from, if there's something going on at night, you ring up and a doctor comes and visits you. We want to change it to an emergency room. And ER was on the telly at that time. So we thought it's got to end in ER. And it started off with a group of GPs in East Birmingham, but we couldn't make anything of it. And then some GPs in North Solihull said, can we join in? And we thought, Birmingham and District GP emergency room. So that's where Badger came from. Of course, later on down the road, people start ringing us up about wild animals that they've been run over on the road. We say, no, we're not a vets, actually. So that's where Badger came from. And that was a success as well. So the multi-fund had been a success, but it was ceased in 2000 or whenever it was. No, sorry, it was ceased when the Labour government came in. It was expanded into GP commissioning, so everybody did it. So you didn't have to get people together, they were just in it automatically. Meanwhile, Badger had been set up and was running successfully. And it's gone on really, it's quite extraordinary. There are not very many GPs who are in organisations like this, where it still has its cooperative root there. Because in 2004, GPs were able to opt out of the responsibility for out of hours. So they didn't have to get together or do anything. They just had to say, I don't want this responsibility anymore. A bit of money gets taken out of their GP practice funding to pay for it, and they can walk away. And then the health commissioner has to commission it, as it is now the ICB. In Birmingham and Solihull, we still have that core cooperative where the practices still have the responsibility for ensuring there are out-of-hours services for their patients, and that's for about 500,000 patients. All the others are commissioned by the NHS commissioners. So it's quite interesting, and we're still there. We've existed through several phases of commissioning with lots of different providers and white-hot competition, as there has been in one or two other areas as well. So we've been tested in the fire, and the two fires that we were tested in the most were the swine flu, which turned out to be a bit of a damp squib. You might say a false alarm could have been used to prepare for the big one, which of course was COVID in 2020, which almost blew us off the face of the earth, but didn't quite.
We'll come on to those aspects particularly. Currently, roughly how many practices are part of Badger, and how many patients does Badger look after at the moment?
It's around about 1.5 million people. So we cover almost the whole of Birmingham and the whole of Solihull. Everybody who's registered with a GP there, and of course anyone who happens to turn up in the city who's not registered with a GP, if it's an out of hours urgent problem. Yeah.
And we know from patient feedback it's such an invaluable service and so well appreciated. And we'll come on to it, but congratulations for Badger receiving an outstanding rating by the CQC.
Yes, I must say I was completely stunned. And I thought, right, well, that's my work is done, or alternatively, there's only one way to go from here. So perhaps this is, I should stop now while I'm ahead.
Now, you mentioned about being prepared for pandemics, and you mentioned the swine flu. With you experiencing and managing urgent care during sort of public health crises like those, what lessons do you believe the NHS should take to be better prepared for future incidences like that?
The learning from the first pandemic was that the NHS is just not systematic about its preparations. It was, you could say, it was a fluke that we happened to be where we were when I believe it was the biggest outbreak of swine flu in Europe happened in West Birmingham. Now, actually, it wasn't until after we were already, steaming on with it that we realised, and one of my senior managers said, this isn't even our area. Someone else does West Birmingham. I said, it's too late now. So some of the learning is, and they've been doing planning and so on for forever, and everyone had to produce their flu plans and everything. And actually, we hadn't been included because we weren't mainstream. So the first thing the NHS ought to do, it ought to have a permanent stock take, which is kept up to date of all its resources, that could be deployed. And in terms of how to do it, there had been no systematic thinking about how to do things at scale. There had been no systematic thinking about whether resources could be diverted from one thing to another, or whether any of the organisations could overnight increase what they were doing. What technology was there anywhere? How could the public health department, public health actually did scale up what they were doing as well, but how could we manage? What did we have? They had to get a load of extra fax machines in and all this sort of thing, and a whole lot of extra people. There was an enormous amount of manual handling simply because the technology wasn't there. We also, I think at the end of that, we didn't learn lessons from it. There was a bit of superficial debriefing, but really not very much else. And things seemed to sort of stumble along. Then everyone sort of breathed a great sigh of relief and said, oh, thank goodness for that. It's all over. And then almost nothing happened. And so we were severely caught short when we got to 2020. We dug out all our old stuff. So the computer systems hadn't had any updating. So we dug out all our old workarounds that we'd had at the time. And actually, in a way, you could say, why didn't the NHS look at, on a system-wide basis, what did we learn from the last time? What workarounds were put in? How were things done? How did public health cope? How did the providers cope? How did we get through that episode in Birmingham? Not just us, but the whole system. What was done? Could we do it again? Can we practice doing that? None of that happened. It was or if it was very superficial. It was just a question of, phew, thank goodness that's over. That's how it felt on the ground anyway, or close to the ground where we were. And actually, we could have been in a state of better readiness. I perceived the same thing this time.
I think I agree with you. It sounds very odd, but it's almost like something from the Hunger Games, where you put in a certain position and those that are prepared or those that know what to do take advantage, and then the rest sort of fail. That there isn't really that top-down leadership and cohesion that we would have expected, almost like the military would have, for instance.
Yeah. I mean, the first I knew about what was going to hit Birmingham was when I got a phone call from some very, very senior, I think he was a public health doctor actually, in London. I was on a train. I'd got my revolutionary BlackBerry in one hand and my sturdy Nokia in the other hand. So I'm talking about 2009 now, who said, we've got an outbreak in a school in West Birmingham. Can you do something? And so I'm saying, I'm on a train, can we talk when I get home? And he said, no, but I need an answer. So I said, yes, of course we can. So I thought, oh dear. So you also need a system which will enable people to size things up, very quickly. And you need people who can make decisions quickly, which means they have to not only have the ability to process risk and feasibility, but also can they carry their team with them, and will they be allowed to do what they need to do? Now, I was moderately naive at that time. I was fairly confident about some things, not at all confident about others. But if I knew I could carry the team, I knew we could do almost anything that we would be asked to do, because I had an idea of the sort of things that might be needed. I was over-optimistic about how quickly it would ramp up, because I thought, well, it'll take a few days or whatever to spread from this school to another school, which was not correct. But actually, on those things, they were small. The only big thing was, would we be allowed to do the things that we needed to do? And if we'd got there and we'd said, this is how we need to do it, and someone had said no, we could then at that point have said, well, okay, you go and find somebody else who can do it. We'll start getting ready to do things our way. So I suppose it's that. So there was that element of what we already knew. Now, I don't know how many other organisations would be in a position to do that. We weren't a big commercial organisation with a huge board of directors that had to be consulted, who would take a while to do it. At the same time, we weren't a GP practice-sized entity, and GP practices were smaller then, who wouldn't know whether they could manage their everyday work with something else on top of it. So learning for me, what did we learn from the last time? But the other thing I've learned through my whole career is, don't keep looking back, because we've got to look at tomorrow. We've got to look at where we are now. So what did we have in 2020? We had social media. We had the ability to function without any infrastructure. We had learned how to do things using the telephone and without seeing people face to face. We had learned how to sort of negotiate our way through a whole lot of things. So when we were looking after people in quarantine hotels, for example, So we knew all about rules and regulations. We were dealing now with the local authority, Solihull, who were totally brilliant, their resilience team, and we were dealing with the Home Office, who were a new thing. I mean, some people do. I know more about the Home Office now. But interestingly, we were not dealing with the NHS. We were dealing with the Home Office. We were dealing with the police. We were dealing with the immigration service. We were dealing with the airport. And of course, we had one of the points in the middle of that was the evacuation of Kabul, which was 2022, I think. And that we sort of scrambled together a team, sorted everything out, put it all in, worked out how we were going to do it, got a rota together. For those few days, I was told we had dealt with more incoming people on planes than they had in the other centres. And the GPs were absolutely fantastic, and the ANPs who were involved in it. It was really close working with the quarantine hotels, the Home Office, the people who were organising the evacuations. So I was getting a message, this patient's, they've stopped at, I can't remember where they were stopping now, somewhere in the Middle East to check things were okay and offload people who needed hospital, but people didn't want to get off there. They wanted to get all the way back here. It was just extraordinary, the teamwork. And I think this is one of the most brilliant teams I've ever worked with. Of course, these were professional resilience folk from Solihull Council. So I've just been in the right place at the right time. The interesting thing about that was bigger organisations had not been able to mobilise. So we were big enough to be resilient and to have a workforce to call on. And I put a message out on WhatsApp to the Badger team, and they escalated it. And I had volunteer doctors from all over the region volunteering services. And of course, we didn't need them all to come, but actually some of them were really helpful. So there was a fabulously helpful paediatric ophthalmologist who was the husband of somebody who'd had something on Mumsnet or something like that. I couldn't believe it, this outpouring of offers. And so there were lots and lots of good people in the world. But the interesting thing was the big NHS organisations, the ambulance service, UHB, NHS 111, really struggled because they couldn't mobilise enough people quickly enough.
Some interesting lessons, and I'm
It is.
sure people can take a lot of lessons from that, particularly with the social networking, but the importance of the relationship building and the trust that you have in your colleagues to have your back. Yeah. Where I think we've really lost a lot of that culture, particularly when there's so much blame and sort of looking over one's back of not knowing what to do and whether you're allowed to do certain things, the repercussions of it, rather than here's something we need to deal with. Let's just get on and do it. Yeah. Who's going to muck in and sort this problem out? Yeah. So bravo for that.
It wasn't me. I didn't do the work.
No. But
I just sat there operating the communication.
But it's just that thing of knowing the right people and who to depend on. Now, there's a famous saying that behind every great woman is herself. So I want to ask you something to do with gender equality and leadership in healthcare. So you've been such a strong advocate for gender equality, equity in the medical profession. What do you see as the current barriers to women's advancement in healthcare leadership, and how can the industry promote more equal opportunities? Well,
I blame society. Although I think it's less society in some ways now than it was. When I first came in, I can remember I went as a trainee GP, and there are not many women around, especially older women. So there were younger women and trainees, and then they disappear. So I felt this isn't right. But they were all saying to me, you've got to do something. I felt as if I'd been captured. So right, now you've got to do it. And I had this feeling, you old women, what do you know? The world is changing. It's not like it was when you were young. We are all equal and all this. How much did I not know? And so when I got a couple of decades in and realizing it's not much better, 20 years in to medical committees, there are just as many men and just as few women as there used to be, despite the fact there's loads more women doctors than there used to be. So what's happening? So I can go to a meeting representing somebody or other, let's say in the BMA. I go to a national meeting. The room is full of men, mostly white men, but not all. And there are 2 women in the room. One of them is the person from the Department of Health, and the other one is me. And they think I am the person who hands around the tea and checks people in, because they just assume that. Oh, dear. Because they know who the person is from the Department of Health. And that's interesting. And I found it very interesting, because actually at this point I was representing UK general practice, but it was actually a hospital issue. So I thought it was quite interesting to find out what happened when they didn't realise there was a GP among them, but that's a different story. So that was how things were. And I realised that it wasn't going to just improve because of numbers. I think we now have a situation in the BMA, I think that there are more female than male members, and yet you look at some of the committees, you look at the representatives who are on, there are you see a few more medical students, but actually some of them, we've never ever had a female chair of the BMA Council, for example. You can get to be deputy these days, and they've had, I think, 2 female deputy chairs of the BMA Council in its whole long existence since 1880 something. So just thinking things are bound to get better, I felt so bad that I'd made the mistake that I said, I'm going to stay on this committee until there are more women. One of the things that happened when I became chair of the Conference of Local Medical Committees, which represents all the GP local committees in the country, I got loads and loads of emails from people saying I was going to leave the BMA. Women. So I was going to leave the BMA, but now there's a woman there. I think I was only the second one. I was the first and only female chair of Birmingham Local Medical Committee. It's a very ingrained masculine culture, doctors, and you still see it. Interestingly, the Royal Colleges have been sort of shamed into doing something about it, and they have often, from the educational side of things, they have often put in special schemes and things, and I think all the Royal Colleges pretty well have had, all the ones that have been around for any length of time anyway, have now had female head honchos, whether it's usually it's the chair you're looking at, rather than the president is a sort of honorific thing. So it's still a thing for me, and I realised I got engaged with it too late. I thought it was just going to happen. So anyone thinks that equality is going to just happen, it isn't. One of the things in the BMA that made a huge difference was when Chan Paul came in, and he came in determined to do something about ethnic and racial equality. And the BMA has made terrific efforts. One of the things that I perceive in relation to gender equality, and one of the reasons it doesn't happen, is because there are such a lot of women. And so people set off and say, we must do something to have more gender equality. And then someone says, but we must do something about disability. And we kind of get sidetracked off gender. But I think there is an unwholesome culture in medicine that feels it's all going to be all right in due course. And actually it isn't. Not only that, I came round fairly early on to thinking, if we don't have quotas, we won't do it. And of course, the democratic principle is, surely you all vote and you get the best person for the job. But actually, it's not like that. It's not like that. We vote for people like us, whatever the like part of it is. But on the whole, I would say, someone like me I would say someone like me is more likely to find things about you that make me think he's like me. He's a GP. He's from this area. I share the philosophy. Than you are to say she's someone like me. Do you see what I mean?
I do.
I'm making presumptions about you, but I think this is part of the problem. So society is to blame because of the way it brings up its girls. I feel that I had a responsibility that I didn't recognise time ago. So I think as people go through the system, they have got a responsibility not to climb the ladder and pull it up, but actually to climb the ladder and then shout down and say, I'll hold the top, you climb. And also to say, keep off this ladder, you.
And for the women joining the workforce, joining the industry, if you had to give one or two messages for them from your previous experiences and from what you've seen on committee meetings and the sort of characters you've met, what messages would you give to encourage them to take on these positions and just keep going for it?
Well, some of these lessons I learned from observation and sometimes by asking people, but keep trying. Women very often, if they say, I want to do that, they get themselves wound up, they go in, they apply, they don't get the job, they don't get the votes, and they go away. And what I've seen in the BMA, they go away and they go to the Royal College. And actually the Royal Colleges are the beneficiaries of this culture in the BMA. It's not just the BMA, but you see it in workplaces as well. So women apply, don't get the job, and they go away. Men don't do that because they're encouraged to be competitive and keep going. And it's a bit shameful to give up, isn't it? So, and that's partly why you see more older men than you see, because the women who are successful young get into it. If they're not successful, they go away and do something else. If the men carry on, they may start their they may start as medical students, but they may start when they're a consultant because they've been having a go for a while and then finally they land. And women go away and find something else to do. Now, of course, the people who want to perpetuate this, or the people who just do it without even wanting to, they say, well, of course, the women have got more important things to do. Of course, the women don't want to waste their time on things like this, do they? And all this kind of thing. And actually, don't be put off, don't be distracted by any of that. Find another woman so that you're not on your own, and find someone who will have your interests. So part of my role, I suppose, in the last 10 years, why was I still on these committees for so long? Why didn't I just go and give up? Because I could have just gone and said, I want a woman in my seat. But actually, I couldn't guarantee that, could I? What's the point of me going if I'm replaced by a man and there's only half a dozen of us on a committee of 80? So I was constantly saying, you should do this. You could say, oh, I'm not good enough. Say, look, why do women have to be special? There are plenty of mediocre men, or let's not say mediocre, let's say good enough. You only have to be good enough. You have to say, are you going to be as good at it as all these chaps you see around you, who it's just what they do. You don't have to be excellent. You don't have to be number one all the time. Although there is a sort of an expectation, but I think we need to get out of this culture of difference. And there's no point saying to the chaps, you've got to be number one and be excellent, otherwise we won't take you. What we need is good enough. I'm really impressed by what's been done, if you like, in all the political parties, really. A moment of great distress and shame to me was when the committees that I was on were less representative than the political parties running the country at the time. And I don't need to say who they are. And whether or not they have women leaders, it's the normal. You don't need to say, oh, we've got a few film stars here. But there's all sorts of things. And you do get into the general equalities thing about use of language and about not just about not being abusive, but care about what you say, things.
Some very valuable lessons there that you shared.
So anyway.
Would like to talk to you about the public versus private sector in healthcare. So, people have been reading Lord Darcy's second report, which is very similar to the first one, and there are hints of further privatisation and people being encouraged to use private services more to reduce the burden on the NHS. How do you see the balance between public and private sector involvement in healthcare evolving over the next decade?
Well, it's perhaps evolution is the right word, because it's just happening in a sort of what I would call an unguided fashion. The only thing really that is restraining, restricting or anything is the CQC regulating. I don't know that the CQC have at the moment got the capacity. I don't know whether they've got the capability. They seem to be in a state of constant review and change at the moment. So whether the capability is there, you have to assume it is, or it's going to be. Whether the capacity is there to cope with multiple small outlets opening up all over the place, I don't know. I can see why. I've worked in deprived areas all through my career. I work for a not-for-profit organisation. I find when I come to look at my pension, it's not as much as it might have been. So again, it's what do I feel? What I want is to be the patient's doctor without being the agent of the state, but I want the state to pay for it. Now that's a bit too much, but that's what I want the patient to feel, and that's what I want to feel. Now I do get the fact that some people want to pay for stuff that they can't get, or they can't get at the time or in the most convenient way via the NHS. And I'm sorry to say that what you can't get seems to be increasing. So things like personal attention from a consultant, so that you know who's in charge, and even recognising whether you're seeing a doctor or someone who isn't a doctor, but everybody looks the same these days and you can't tell. So who are you getting the service from? What sort of service are you getting? There's enormous rationing. It's concealed. It used to be, it was a waiting list. It's concealed now. It's not just a waiting list. There are plenty of those, but there are all sorts of means of rationing, whether it's by changing the way the system works, moving the hospital further away, or whatever. Or also changing other services other than healthcare that provide something similar and are now closed because of financial restrictions. Again, if we look at local authorities and the things that have happened in there, because the things they have to do as a mandatory are taken away from discretionary type of things, and people are turning to where else can we go. So, and so what happens in healthcare is being restricted by various means, and I can see why people want to pay. And if they disappear, of course, you have to pay. I mean, I pay for my dentist. In fact, my dentist isn't even in the UK because I have connections elsewhere. And I had to consult a dentist. And he was so fantastic that I thought, I'll come back here the next time then. So that sort of thing. Now, where do we go from there with my ideology? Because actually what I don't want to happen in health is what I have seen happen in education, which is that the articulate, the sharp-elbowed middle classes, as they're called, if you keep them in the system, they make it improve. And it doesn't just improve for their children, it improves for everybody round about. You will always have people who can afford to pay private school fees, including VAT, and so on, and that's their choice. And there's always going to be that sort of a market. I would like to get the majority of the population for choice things back into the NHS. But with the latest report from Lord Darcy, I think there are two things. Number one, he's saying more should be done outside hospitals. Absolutely agree. The government's saying, get that going then, but there are no resources. And I've had that message all the time. All that we've done in Badger has been done with a minimum of resources. And we certainly haven't seen, we had money at COVID, which has gone. So we have had tiny uplifts because we're not part of the hospital sector, so we don't get their uplifts, and we're not part of general practice, so we don't get their uplifts either. So no 22%, no 6% even. So what we've had to do is to learn how to do things. And I think some organisations have had to scale up and it's scalable. We saw what it was scalable to in the events that I've talked about. So I think there's some learning there. I'm very keen on lots of people working together. So we've done it with 2 organisations. I don't see why you couldn't do it. We did actually develop a big GP practice plan in 1996 in Birmingham. And it was so shocking. So many people wanted to join that we decided we'd have to have a membership fee. So we put in a high enough fee that would discourage some people, but we still had, we started off with about 700 GPs wanting to join it. So actually, ultimately, it went up to the Department of Health. This was a giant APMS. It was a giant PMS, which is primary medical service, different type of contract. And we thought we've cracked it here. They'll either agree or they won't agree. If they don't agree, we'll appeal. They didn't do either. They said, we are going to adjourn this decision. But actually, I could see it then. And the group of us and a lot of the GPs could see it in 1996. It's just coming around now, but it's not happening in the same way. It's happening on a more commercial basis. And the problem is there, you are doing it sort of on a different basis. So you're doing it on the basis, even if these are NHS contracts, because you have to have your shareholders who have put in the investment, so they want to get something out, and you have to do it on this basis. This is what rankles with me. The other way of doing it, of course, something's come out pretty recently, reports from the latest report from Northumbria, I think, Healthcare, who is now running a lot of GP practices. So there's some big GP practice groups in varying degrees of commerciality. We've seen the origins of some of them in the West Midlands, but in other parts of the country as well. And so these are various types of NHS, and they've got NHS contracts of various sorts. The Northumbria one is interesting because it's being run by a hospital. I'm wondering what happens when you get through the generation of GPs that kind of, the oldest ones are my age, the younger ones are your age. What happens when you get through that, those generations of GPs who are more partnershipy, relationshipy type of working into a much more transactional system, which is, started with purchasing and providing in the NHS, but has actually evolved, if we go through from 2012 and go through there. What happens when it's all done on that sort of a basis? The interesting thing about the reports from Northumbria are that the hospital had to put a shed load of money in to get it going, and now it's running. And it's running with lots and lots of salaried GPs. Now, the other organisations who are further down the line tend to have fewer GPs and more other types of healthcare professionals. But there has been no policy decision that we should run the health service on that sort of basis. We know in personally paid for services, that what people pay for, they will pay for. They particularly want to see doctors. So it's interesting. But I can't see any other way that it's going to go, Atif. So if it's going to be commercial, a bit like way back there in the 1990s, if we've got to have fund holding, let's make it work for the patients, for the system. Let's make it fair. Let's make it as good as it can be, and as equitable as it can be.
What do you see as some of the biggest challenges and opportunities for primary healthcare delivery in the UK, particularly post-pandemic?
Well, there's always opportunity, however glum things look, there's always opportunity. So, even if it's just the opportunity to survive. So I would say, like I'm saying to all those women doctors, don't give up, keep trying. Don't just keep banging your head against the same brick wall, find another way around. I think the big opportunity now is, like I was way back, technology. Technology will help us do what we do well without compromising, I think. So technology at the moment, we can run a virtual waiting room, which means that we can run more efficiently. So if you were a doctor working at Badger, it may be that you have a 10-minute consultation on the phone, but you may spend 2 or 3 minutes, let's say, at the least, looking up your next patient, dialing their phone, waiting for someone to answer. And then at the end of the consultation, you might spend 5 minutes writing up your records and things. Well, you know what? If we could have that first 3 minutes and that last 5 and add them together, you've got 8 minutes. You could almost do another consultation. Do you know what I mean? So actually, and the quality of everything would be the same for the doctor and the patient. So there are technologies that will do this. Now, what we smart people have to work out is how can we fit them into our system? How can we make the flow so that the patient gets the same amount of access, maybe easier. Maybe the patient can book themselves in instead of having to go through some other bit of system before they get to us. You know, maybe you just sit there at home and say, I'd like to speak to somebody this afternoon. I'd like to speak to a doctor this afternoon. Booked in. Yeah. And then, like, I don't know, when I went to sort out my mother's credit card that she thought someone might have copied or something. So I ring up the bank and the bank thing says, do you want to hold the line for however long it takes and it's some inordinate length of time, or we can ring you back? And I said, I'll press button B for ringing you back. Didn't even have to press button B because it recognised voice, you know, but they're much more sophisticated in banking than we are in the health service. And I'm thinking, why can't we do this? We should be able to do this. You know, we can cut out all the rest. Now, all those people who are working as call handlers in call centres and things will all be replaced by automated systems that patients have got direct access. The other thing is, we need to trust the patients, you know, and not say, are you sure you need to see a doctor? Or tell us whether you've got a cough and then brackets will exclude you. We don't do any of that. If it's something we can't do, if they say, my tooth needs a filling, well, we don't have any dentists, so that's an easy one. But, you know, all this sort of thing, we need to learn, we need to keep moving. If there's less money, we've got to do more with the resources that we've got, and that's the human resources as well. So all those people who are call handlers, we actually could do with getting them to be, I don't know, healthcare assistants, and then nurses, and then some of them will go on to be doctors. So this is another joy of Badger. So some people who've joined us as receptionists have gone on and eventually come out at the end as a nurse, as a paramedic, as a doctor. Not always in health. We have social workers and people like this as well. So this is one of the things. So you can see what gets me going. I can talk forever.
It's hugely inspirational. In fact, it's very interesting that you mentioned technology. I was at a small conference at the House of Commons, and John Caldwell released a report to try and how to make Britain great again. And the thing that he's sort of pioneering is technology, and how do we use green technology and get all these bright people within the country to develop tech to streamline such sort of services rather than outsource it or sell it abroad for then us to buy it again.
I know, frustrating. But the thing is, it's not just, you've got to have your inventors, but you've also, you've got to have people who can operationalize it. And then you've got to have people who will say, come on, guys, let's just do it. Let's not wait till it's perfect. Let's do it now, adapt, work round. We know how to do things from previous experience, so let's go forward with this. The thing that I wished I'd known about before COVID, a long time before, was what I know as systems engineering, which is process management and so on, design, and I wish I'd known more about that. So I think a bit more of that will help us use technology optimally. It's not just a question of getting more machines. We've also got to say, how can we do it all within the finances available? Anyone can talk about a better machine. Anyone can talk about a bigger computer. Anyone can say, oh, we could have robotic this or that or the other. But actually, you've got to get from the brilliant idea. The stuff's all out there. It's a question of how can we get that stuff into our environment alongside what we've already got. And how can we do that without, in an affordable way? Because, if someone came along and doubled our budget, there's a whole lot of things we would do immediately. But what we have to work out is how to do the change, and then how to make what follows sustainable, but not fossilize it, because it's got to be continually improving. So
I think you've summarised it perfectly well, and the affordability is always the magic question.
Yeah.
I'm going to leave the audience with something that you just said that really sums up you and the work that you've done, the organisations that you represent. Just do it because it's the right thing to do. So, Fay, thank you very much indeed, and look forward to speaking with you again.
My pleasure. Thank you very much.
If you have any questions, feedback, or you'd like to learn more about how we can help your organisation, please don't hesitate to get in touch. Our contact details are in the description below. Don't forget to subscribe to our podcast for more episodes and updates. You can also follow us on LinkedIn, Facebook, and Instagram. Once again, thank you for listening or watching, and see you soon. We are the Health Group. We work with the new and existing healthcare providers every single day, from private clinics to adult social care services and NHS trusts, to ensure all providers are compliant with regulations, have a culture of excellence, and are delivering exceptional care.